If water is the problem, then deresuscitation maybe is the solution. Today I will try to share with you some of the tools that we may use to monitor deresuscitation. I have to disclose I'm a member of advisory board of Göttingen, and on the next slide you can read my other disclosures. So after a brief introduction, I will tell you about the what, the why, the when, and the how to deal and monitor deresuscitation. So let's start with a brief introduction, which is that we need to try to find answers to the 4 basic questions: when to start fluids, when to stop giving fluids, when to start fluid removal, and finally, when to stop fluid removal. Of course, we must avoid hypovolemia. So what are we talking about today? So the definitions of fluid balance and fluid overload are important. Fluid overload is defined as a cutoff value of 10% of fluid accumulation in liters by patient's baseline body weight. Early adequate goal-directed fluid management is an average 30 ml per kilo within the first 3 hours, as the sepsis guidelines advocate. Late conservative fluid management is 2 consecutive days of negative fluid balance within the first week, and late goal-directed fluid removal is active fluid removal by means of diuretics or ultrafiltration, and this is referred to as deresuscitation. So recently some publications came out telling us about the 4 phases of fluid therapy, and I must tell you that the acronym or the 4 phases is a slight preference for R.O.S.E over S.O.S.D on the social media. Soon you may read this review paper, which will be published in Annals of Intensive Care. So let's go back to the R.O.S.E concept. The patient is in shock, we need to resuscitate, optimize, support the organs, stabilize the patient, going to homeostasis, and then maybe at some point we may need to deresuscitate and to evacuate, hence the R.O.S.E acronym. So after first hit, fluids are life-saving, can rescue the patient. Now we must optimize, support the organs, stabilize the patient, and most of the patient will evacuate the fluids themselves. And when we are actively evacuating or deresuscitating, we must avoid hypoperfusion, hence the acronym R.O.S.E. I must tell you that with the blossoming of the rose, the last rose is just a dry rose, it's not a dead one. And I'm happy to see that the R.O.S.E concept has been picked up in the literature as well. So the problem is that if we look at the publications on the different phases, most of the studies focused on after the initial resuscitation. Only a few looked at the very, very early moments in time, and only few studies looked at deresuscitation. So it's a bit confusing to translate this into clinical practice, because it brings us back to the ebb and flow phase of shock. The ebb phase, the patient is underfilled. We may look at endpoints like pressure or hemodynamics, passive lag raising. When the patient is overfilled, we may look at organ function. So if you go back to the 4 phases, from rescue with goal-directed therapy to optimization with late conservative fluid management to stabilization, and then maybe late goal-directed fluid removal to evacuate the excess of fluid. The initial phase, we may look at pressure, passive lag raising, and we stop giving fluids when everything normalizes. But what are the parameters that trigger us for deresuscitation? That is what we need to find out today, to set the right targets in order to reach the right goals and avoid fluid overload. So why is this important? Well, because peripheral edema and anasarcodema is not only of cosmetic concern. It is a real threat to the patient, and it has been associated with worse outcome in sepsis. Fluid overload has been associated with AKI, or worse outcome in ARDS. The reason is that a positive fluid balance is an independent prognostic factor of patients with sepsis, and we should favor restrictive fluid management, because fluid overload has a dramatic impact on end organ function and may lead to the global increased permeability syndrome. So late conservative fluid therapy may be even more important than the early adequate, as you can see in these studies. The one for Europe is the classic trial. So when should we think about deresuscitation? The patient is not transgressing from ebb to flow phase. So after the first hit, there is this response, we give fluids, ischemia, reperfusion, and then most of the patient reverse shock and get a spontaneous negative fluid balance. But some of them will remain in an unresolved state of shock and fluid accumulation. So GIPS is the persistent positive cumulative fluid balance with new onset organ failure. So how to assess hypervolemia and how to monitor deresuscitation? What tools can we use? I've read a very nice book by Ronco and Bellomo. But basically there are some clinical parameters that you could look at: biochemical parameters, imaging techniques, advanced hemodynamic monitoring, looking at organ function, so the impact of fluid overload, or maybe other techniques like bioelectrical impedance analysis, electrical impedance tomography. So I can tell you that clinical signs are not very specific, nor are biochemical signs, and nor is the standard static chest X-ray imaging. Also, because of time's sake, I will not focus on clinical examination nor ultrasound. I know that when inferior vena cava collapsibility index is low, that the patient is probably fluid overloaded, although it could also be related to mechanical ventilation. There are many good reasons to practice ultrasound, and if you find B lines, this may also be an indicator of fluid overload. I'm not going to talk about plasma protein concentrations for diagnosing weaning-induced pulmonary edema, nor about iatrogenic hemodilution, which are also important. I think we need to individualize and standardize our approach, avoiding hypo, but also hypervolemia. So each patient merits an individual approach. So what about passive leg raising tests to guide fluid removal? An interesting study by Xavier Monet and Teboul. So if there is no increase in cardiac index, so these patients don't have intradialytic hypotension. But if they were fluid responders, pressure will drop. What else? Well, if you look at volumetric preload like global and diastolic volume, this might be a good indicator. I like cardiac output, and is my friend. Friends come with benefits. I would say use the benefits. Go for transpulmonary thermodilution monitoring. You will have a lot of information readily available at the bedside. So you could use global end diastolic volume, and you may correct it for the ejection fraction, but in fact a volumetric preload is much better than a barometric preload to guide the resuscitation. What else? Well, you could look at extravascular lung water as a guide for deresuscitation. Because if extravascular lung water drops with more than 2 ml per predicted body weight, it's a good prognosis, and we call this a responder. And responders have a less positive cumulative fluid balance than non-responders. Late conservative fluid management has a better survival, faster weaning, and this is also the case for responders, so those who drop their extravascular lung water. You could look at pulmonary vascular permeability index, as did again the group of Monet. And the PVPI is the relation between the extravascular lung water and the pulmonary blood volume, and it allows us to differentiate between permeability pulmonary edema and hydrostatic pulmonary edema. This has been studied in dogs, shown that the PVPI is much higher if there is a hyperpermeability edema. And again, Monet translated this into the clinical setting and shown that patients with ARDS have a higher PVPI, and it allows to estimate the lung permeability better than BNP. So what about abdominal pressure? One of my personal biases. Indeed, you could use abdominal pressure to guide your deresuscitation, as abdominal pressure may drop and diastolic volume may drop, and also the extravascular lung water. What about other parameters like bioelectrical impedance analysis or the extracellular water? Let me present you a case who has a poor status after trauma with ARDS, an extravascular lung water of 16 and a fluid excess of about 5 liters measured with BIA. So this is a patient, a high extravascular lung water, so we treated with percussive ventilation, high PEEP, Furosemide, so the next stage, chest X-ray, much better, a drop in extravascular lung water. And we saw that the fluid status improved with only 2.6 excess. Urine output went down, so we put the patient on CVVH, and we came down with fluid balance and finally reaching a 0 fluid excess. And with the new BIA device, you can also measure the quality and the efficiency of dialysis, KT/V. You can see the evolution of extracellular water. You can see the evolution of a patient going from the edema site to the normal site. We tested BIA in healthy and critically ill and found that ICU patients have much higher volume excess. And there is a difference between survivors and non-survivors. Non-survivors having a higher volume excess and a higher extracellular-intracellular ratio. And this could allow to define fluid overload by measuring the volume excess. So the more fluid overload, the more likely you're going to die in ICU in the hospital. And this was statistically significant. So one more thing. What about the Furosemide stress test, which has been used by nephrologists to predict AKI and to test tubular function? But you could invent a ready for deresuscitation test by giving just a small dose of Furosemide of 5 or 10 milligrams and look at the urine output in the following 2 hours. Just one very last thing is, what I alluded to the PAL treatment, is that you set the PEEP to the intra-abdominal pressure, you squeeze the fluids out of the lungs into the interstitium, and then by adding the hyperoncotic albumin, you may attract the fluids from the interstitium to the intravascular space, and by adding the Furosemide stepwise after 30 minutes each, you may clear the lungs. We did this in a pilot study, so the patients in the PAL group and a higher PEEP albumin was substituted, and after 1 week of treatment, this resulted in a drop in abdominal pressure, improved oxygenation, drop in extravascular, and this by keeping the cumulative fluid balance in balance, resulting in a better survival and a faster weaning. So, ladies and gentlemen, to wrap things up, I would like first to extend a kind invitation to join us for the next Fluid Academy days at the end of November. And if you can't wait, join us in Dubai beginning of April. So we'd like you to go home with the following messages. Fluid overload is defined by a cutoff value of 10% increase in body weight of fluid accumulation associated with increased mortality, morbidity, and organ failure. And this is what we refer to as GIPS. It's all organ function, with the absence of transition from ebb to flow. So how to guide your deresuscitation? Clinical and lab signs were specific, not going into detail, but protein and dilutional anemia. Static imaging, chest X-ray is specific. You might use POCUS and look at the inferior vena cava, collapsibility index, and B lines. You can use volumetric preload assessment. The absence of fluid responsiveness may be a good indicator, so a low PPV or a negative passive leg raising. Always assess organ function. Avoid hypoperfusion in your deresuscitation phase, and maybe in the future we could use BIA and EIT. I thank you for your kind attention.